Welcome to the Deep Dive, your shortcut to the specialized knowledge you need to excel clinically. Today, we are taking on a massive topic, contraception. We're focusing specifically on how these powerful pharmacologic agents work, and maybe more importantly, how you choose the right one for your patient.
Yeah, absolutely.
So contraception, it's defined as inhibiting pregnancy through, a method, device, or process. Since the FDA approved the pill back in the 1960s, we've seen huge societal shifts, and that includes a real decline in unintended pregnancies. By 2011, that percentage had dropped from about 51% down to 45%. And those decreases, well, they don't just happen, they're really driven by informed clinical practice.
And that's really our mission for this deep dive, isn't it? To move beyond just basic memorization. We need to really understand the precise mechanisms of action, compare and contrast across the whole toolbox,
Yeah.
and figure out how to formulate an individualized plan. And we're seeing a major shift in practice, too. I mean, oral contraceptive pills, OCPs, and female sterilization are still very common. But the use of long-acting reversible contraceptives, LARCs, so the IUDs and implants, that's really surging, mostly because of their superior practical effectiveness. So to manage this whole arsenal, we have to start with the basics, the target.
Exactly. Before we even talk about interrupting the cycle, we kind of have to grasp how the normal hormonal cascade works. How it creates the opportunity for pregnancy in the first place.
Okay, so the natural cycle, we can break it down into two main phases. First, there's the follicular phase. That's driven by follicle-stimulating hormone, FSH. FSH basically tells the ovaries to produce estrogen, and that leads to the development of the dominant follicle. But the real target, pharmacologically speaking, is the late follicular phase. See, normally high estrogen suppresses gonadotropins, that's negative feedback. But when estrogen hits its peak concentration, it flips a switch. It's pretty neat, actually. That massive surge of estrogen causes a quick shift to positive feedback, and that triggers the crucial luteinizing hormone, or LH, surge.
Ah, the LH surge. That's the key signal.
That's the immediate signal for the ova to release. So contraception aims to hit one of three goals: block ovulation by messing with those hormonal peaks, prevent fertilization, or interfere with implantation later on once the luteal phase starts.
So basically, if we can shut down that positive feedback loop, we stop the whole show before it starts.
Pretty much.
But let's maybe look quickly at methods that don't rely on systemic hormones first. We have those foundational non-pharmacologic methods like the rhythm method, which is only about 76% effective, so not great. It requires really intense patient compliance, tracking basal body temperature, which rises just a tiny bit, zero point 0.4 to zero point 0.8 degrees Fahrenheit after the LH surge, and checking cervical mucus changes.
Yeah, it's a lot of work for the patient. And of course, you have Berry methods, diaphragm, cervical caps, condoms. For advanced practitioners, though, the most critical clinical distinction, and you really can't stress this enough, is this. The male latex condom is the only contraceptive proven to prevent the spread of HIV.
That is such a key point. Needs repeating.
Absolutely. Now let's talk efficacy for a second. If you look across the board, the intrauterine device or system, the IUD or IUS, it's arguably the most effective method of reversible contraception we have. The clinical failure rate is less than 1%.
Less than 1%.
Compare that to the typical failure rate of OCPs, which, in the real world with missed pills and everything, often sits closer to 9%.
9%? That's a huge difference.
It is, and this is why LAR-VASers are gaining so much ground. That gap between perfect use and typical use is much smaller.
That contrast in practical failure rates, less than 1% versus potentially 9%, that's a really vital insight when you're starting the conversation with the patient, deciding where to begin.
Precisely. And if we look at the copper IUD specifically, it's actually a brilliant non-drug method. It basically acts as a spermicide, and it also interferes mechanically with sperm transport. It makes the intrasonate environment hostile to sperm, all without using exogenous hormones.
Okay, all right, let's move into the hormonal foundation then. Combined hormonal contraceptives, CHCs. So these include the OCPs, the transdermal patch, and the vaginal ring. Clinicians often choose these first, partly because they offer high efficacy, that perfect use failure rate is still under 1%, and patients usually expect a pretty rapid return to fertility when they stop. But I think the real selling point for a lot of patients are the non-contraceptive benefits, right? We're talking about significantly reduced risks of ovarian and endometrial cancers, which is huge. And also major improvements in things like acne and hirsutism, those androgen-driven conditions.
Yeah, that improvement in androgen symptoms is directly tied to the estrogen component. It's quite interesting. Estrogen dramatically increases the liver's production of sex hormone binding globulin, or SHBG. So more SHBG means less free testosterone floating around, and that's why you see the acne and hair growth decrease. It's a really significant benefit beyond just birth control for some people.
Okay, so how do they actually work, the core pharmacology of these CHCs?
Right. So they work by maintaining continued high circulating levels of both estrogen and progesterone. This effectively suppresses the pituitary gonadotropins, both FSH and LH.
Right.
Now, the progestin component is really the heavy hitter here. It primarily suppresses that LH surge, and that's what blocks ovulation. The estrogen component then backs it up by suppressing FSH, which prevents the selection and development of a dominant follicle. So it's like a complete suppression of the whole axis.
Got it, a two-pronged attack. And we manage the dosing complexity with different types, right? Monophasic, biphasic, triphasic.
Exactly. Monophasic uses the same dose of both hormones for 21 days. It's simple, straightforward, and often easier to adjust if side effects pop up. Biphasic and triphasic regimens, they try to mimic the natural cycle's fluctuations by varying the dose every 7 or 10 days. Usually this results in a lower net dose of progestin over the entire cycle. And we also use extended cycle OCPs. These minimize or even eliminate the hormone-free week. This can be a clinical necessity for some patients because that traditional 7-day break lets the body's own estradiol recover, and that can increase the risk of rebound headaches or even follicle development starting up again. So by shortening that interval, we ensure continued suppression.
Right, makes sense for managing side effects like headaches.
Yeah.
Okay, before we move on, we absolutely have to address drug interactions. This is crucial for advanced practitioners. Which ones really gut the effectiveness of these pills?
Yeah, this is super important. We worry most about anything that ramps up the CYP3A4 enzyme pathway in the liver, because that's how ethinyl estradiol gets metabolized. The classic examples are certain anticonvulsants like phenytoin and carbamazepine, and crucially, the antibiotic rifampin. These are CYP3A4 inducers. They basically crank up the metabolic engine, which just shreds the estrogen level, and that can render the pill ineffective.
So rifampin is a big one. What about other antibiotics?
Well, the absolute risk with most broad-spectrum antibiotics is probably low, but concurrent use of rifampin definitely requires absolute backup contraception, no question. For some others, like tetracyclines or azithromycin, while data is mixed, advising backup isn't unreasonable, just to be safe.
Good to know. Okay, so when a patient starts a combined pill, how quickly is she protected? The common starting regimens are the day one start or the Sunday start, which just helps avoid weekend menstruation, mostly for convenience. But the rule you absolutely must remember is this. If the patient starts the pill more than 5 days after the start of her last period, she must use backup contraception for the next 7 days.
7 days. Got it.
We should also probably briefly mention the other CHC delivery systems. There's the transdermal patch delivering hormones through the skin applied weekly for 3 weeks, and the vaginal ring, which often allows for lower overall hormonal doses because it bypasses the liver and GI tract, so you minimize that first pass metabolism effect.
Right. Different route, same goal. But here's where we hit the massive clinical firewall, the absolute contraindications for combination OCPs. If you take only one thing away from this section, it should be risk stratification related to VTE, venous thromboembolism, a history of thromboembolic disorders. So MI, stroke, DVT, definitely out. Markedly impaired liver function, known or suspected breast cancer, also out. But the critical absolute hard line is this. Smokers older than age 35.
Ah, yes, that's the classic case study one you see in textbooks, right? A 36-year-old smoker comes in asking for the pill, and the answer has to be no for combined hormonal contraceptives. The risk of VTE and stroke is just dangerously high, and it outweighs any potential benefit.
It's a complete non-starter.
Yeah.
Absolutely. And because these risks, like VTE and stroke, are potentially life-threatening, patient safety relies heavily on teaching them the AC warning signs. You absolutely must counsel patients to report severe abdominal pain, chest pain, persistent headache, eye problems like blurred vision or vision loss, or severe leg pain. Those are the immediate red flags for VTE, stroke, or maybe severe liver problems.
Aches.
Got it. That's a really important counseling point, and it sets the stage perfectly for our plan B, so to speak. If we have to rule out estrogen because of clotting risk or other reasons, the patient needs to move to the progestin-only methods. So that's the mini pill, DMPA injection, the implant, and the hormonal IUDs.
That's right. These are definitely the preferred choice for women with estrogen contraindications. That includes women with, say, high blood pressure, a history of thrombosis, are smokers over 35, or women who are breastfeeding.
Okay, let's dive into the progestin-only pills first, the POPs, often called the mini pill.
Okay, the mini pill. Here's a really crucial nuance you need to grasp. The mini pill does not consistently suppress ovulation the way combined pills do. Its main contraceptive effect actually comes from altering the cervical mucus, making it thick and viscous, basically impermeable to sperm, and also changing the uterine lining, the endometrium. Now, because this mucus barrier effect wears off pretty quickly, the strict dosing is absolutely essential.
How strict are we talking? If the pill is taken more than 3 hours late, just 3 hours, the patient requires backup contraception immediately, usually for the next 48 hours.
Yeah.
That very tight window makes compliance quite tricky for some patients.
Yeah, 3 hours isn't much leeway. Compare that level of precision needed for the minipill to the depot injection, DMPA, Depo-Provera. That's dosed intramuscularly just every 13 weeks, so compliance becomes incredibly simple for the patient, and its mechanism of action does reliably suppress ovulation. But there's always a but. The trade-off here are the side effects we have to counsel on.
Right, DMPA isn't without its issues. We often see weight gain, irregular bleeding is very common, sometimes amenorrhea, lack of periods altogether, and significantly, there's a potential for a reversible loss of bone mineral density with prolonged use. It even carries a box warning for this.
Wow. So that means,
So for any patient on DMPA long-term, counseling on adequate calcium and vitamin D intake is really essential. The bone density loss is generally reversible after stopping, but it's something to monitor.
good point. Then we have the implants, like next line.
Yes, the implant. It delivers etonorgestrel, a progestin, and it's highly effective for up to 3 years. Its main MOA is blocking the LH surge, so it prevents ovulation. Efficacy is fantastic, similar to sterilization or IUDs, really up there. And another plus is that fertility returns quite quickly upon removal.
Okay, and here's where some advanced nuance comes in, I think. Since POPs and DMPI are often used specifically in patients who have VTE risk or other estrogen contraindications, why is the implant sometimes listed with a contraindication or caution for women with active liver disease or a current or past history of thrombosis when the mini pill often isn't? That seems a bit counterintuitive.
That's a great question. It relates to the specific progestin type, etonogestrel, and the consistent, relatively higher systemic dose delivery compared to the mini pill. While the absolute risk is likely still very low because you have this continuous systemic exposure from the implant, it carries a specific warning or contraindication in guidelines regarding active thrombosis or liver disease that you don't typically see with a very low-dose mini pill, whose effects are more localized, especially on cervical mucus. It's one of those key details that might push us back towards, say, a hormonal IUS, which acts almost entirely locally within the uterus for certain high-risk patients, even though both are progestin-only methods.
Okay, that distinction about systemic versus local effect, even within progestin-only methods, is important. All right, moving to the sort of last resort option, emergency contraception or EC. What are the choices there?
So for EC, we have basically 4 main choices. First, the copper IUD. It's actually the most effective EC option, and a huge bonus is it can be left in place for highly effective ongoing contraception. Then you have LNG, that's levonorgestrel, like Plan B one-step, often available over the counter. Third is ulipristal acetate, or UPA, brand name Ella, so requires a prescription. And finally, there's the older combined estrogen-progestin USP regimen, but that's generally the least effective and tends to have more side effects like nausea.
Okay, 4 options. What's the key factor for using them?
Timing. Timing is absolutely the defining factor here. All oral options should ideally be taken as soon as possible, but they show efficacy up to 120 hours, or 5 days, after unprotected intercourse. The copper IUD can also be inserted up to 5 days after. One important point is that LNG, the Plan B type, may be less effective in women with higher body weight or obesity. And here's a crucial interaction pearl you need to know. UPA, ulipristal acetate, works as a progesterone receptor modulator. So if a woman takes UPA for emergency contraception, you must counsel her to wait at least 5 days after taking it before she resumes or starts her regular hormonal contraception, like her daily pill.
Why wait 5 days?
Because if she starts her regular progestin-containing pill too soon, the progestin could interfere with UPA's effectiveness, and conversely, the UPA could potentially blunt the pill's initial effect. So a 5-day wait, and use backup-like condoms during that time and for the first week of the new pack.
Got it. 5-day rule for UPA. Okay, finally, let's talk clinical management, because we know side effects are a huge issue. The chapter mentions that maybe 25% to 50% of women stop hormonal contraception within the first year, often due to side effects. So how do we manage the most common complaint? Breakthrough bleeding.
Yeah, managing side effects is key to adherence. For breakthrough bleeding, we actually follow a very systematic, pretty simple clinical rule that's derived from understanding the hormone ratios. It's outlined nicely in box 54.1 in the text. Here's the rule of thumb. If the breakthrough bleeding or spotting occurs early in the cycle, say in the first half, days 1 to 10 or so, that generally suggests insufficient estrogen.
Why estrogen?
Because estrogen is primarily responsible for stabilizing the endometrium, the uterine lining. So if there's not enough early on, the lining can be unstable and shed irregularly. The fix. Usually you need to increase the estrogen dose in the pill.
Okay, early bleeding means needs more estrogen. What about late cycle bleeding?
Conversely, if the breakthrough bleeding occurs late in the cycle, so closer to the placebo week, maybe days 10 to 21, that suggests insufficient progestin activity. The progestin is needed to maintain the lining that the estrogen built up. If it's not potent enough towards the end, the lining might start to break down prematurely. So in that case, you typically need to increase the progestin dose or switch to a pill with a more potent progestin.
Early bleeding, boost estrogen.
Yeah.
Late bleeding, boost progestin. That's a great clinical pearl. What about other common complaints?
You can apply similar logic, thinking about the hormonal effects. For example, if a patient reports really heavy withdrawal bleeding during the placebo week, or maybe significant bloating or nausea, that often points to too much estrogen effect, building up the lining excessively. The solution: try lowering the estrogen dose. On the other hand, if she reports things like increased depression, mood swings, maybe fatigue, or even elevated blood pressure, that might indicate too much progestin effect for her. So you look at lowering the progestin dose or switching to a different type of progestin. It's really about balancing that estrogen-progestin ratio for the individual patient.
That systematic approach. Early bleeding needs more estrogen, late bleeding needs more progestin, heavy bleeding might be too much estrogen, mood issues could be too much progestin. That seems like the highest yield takeaway for troubleshooting in everyday practice.
It truly is. It gives you a logical starting point. So our key therapeutic summary, wrapping things up, is this. Proper contraceptive selection always demands a thorough initial assessment. That means getting a good history, doing a pap test if indicated, checking pregnancy status, blood pressure, BMI, and often getting a lipid panel, especially for potentially higher risk patients starting combined methods. This is all geared towards correctly identifying those absolute contraindications we talked about. And then once a method is initiated, successful management often hinges on your ability to listen to the patient's experience and adjust those estrogen and progestin components based on timing and the character of any adverse effects they report.
Excellent summary. And as you, our listeners, move forward applying this knowledge, maybe consider the really comprehensive long-term impact these agents can have. Beyond just preventing pregnancy day to day, remember that non-contraceptive benefit we mentioned earlier. Long-term combined OCP use can reduce the risk of ovarian cancer by something like 50% to 60%. And that protection can last for 10 or even more years after the patient stops taking the pill. It just highlights how these pharmacologic agents can really shape a woman's health trajectory far into the future, well beyond their immediate use. Thank you so much for joining us for this deep dive.